Great. Thank you, Lance. Thanks for the program committee for inviting me to speak here. It's really a true pleasure. So when we talk about hypothermia, not as is used in cardiac surgery per se, but we'll get to some resuscitation, some crazy resuscitation stuff. I do have to disclose I'm a co-author of a patent for which I'll get absolutely nothing out of this, and I'll explain what emergency preservation and resuscitation is as we go along. We do have grant support from the Department of Defense, and I'll be talking about the use of saline or salt water that we use for resuscitation and cardiopulmonary bypass in ways that it has not been used before. So this is a nice segue, I think, from Dr. Milas's talk about cardiac surgery, because cardiac surgeons use hypothermia before they do something to somebody where they have to stop the circulation to the heart or the whole body. And as was shown already, this was initially done just immersing people in cold water, and then we had the original heart-lung machines. They're very difficult to work with, required a lot of people to get this to work. And now we have more simple machines that are pretty easy to set up and easy to use. But the important part of this for the part of cooling is that these devices are really good at controlling temperature, because you've got this lower part of here with a heat exchanger that can control temperature very precisely. But again, that cardiac surgeons can do this before they cause a problem. For resuscitation, where Dr. Becker and I work, where we're trying to save people who are already trying to die, we don't have that luxury. We're trying to do something quick to save them. So how did I get interested in this? Well, I was a medical student at the University of Pittsburgh, wanted to do something for the summer, wanted something maybe to do some research, and I happened to answer an ad that was on a little piece of paper and posted on a little cork board on the wall, back in the days. Looking for medical students to do cardiac arrest research, and little did I know the person that I would meet is Peter Safar, who's known as the father of CPR, shown here. And just a quick comment about Peter, then the resuscitation work that he did, probably one of the most important things he did is show that mouth-to-mouth resuscitation works. And you've all been taught how to do this. This is a picture on your left of Dr. Safar, this is around 1960, doing mouth-to-mouth on an anesthetized, paralyzed volunteer who happened to be a surgical resident at the time. There's also a video of a medical student doing mouth-to-mouth on this volunteer for 30 minutes. And as far as I know, they both are fine. But the picture on the right is Callenhoven, Jude, and Knickerbocker, who, when Peter did this work at Baltimore City Hospital, which is now Hopkins Bayview, Callenhoven, Jude, and Knickerbocker were at Maine Hopkins, and they demonstrated in animals that pushing on the chest actually produced a pulse, and this happened to be occurring all at the same time, all in Baltimore. And this led to what we all know as the ABCs of CPR. But I'll point out that in this description of the ABCs from Dr. Safar on 1961, he already included H, hypothermia. If the person is not waking up after 30 minutes, you should start cooling them. It just felt like that was the right thing to do, not based on a lot of data. But that was 60 years ago. Now, as I said before, cooling before something happens is easy to show that that's beneficial because you decrease the need for oxygen in the body. And one of the things that was interesting is that in animal models, people didn't think 1 or 2 degrees would make a difference. It turns out that in a number of models, if you cool an animal just before you give them a cardiac arrest, they do better. Who knew that a couple of degrees would make a difference? The bigger question is, if they've already had a cardiac arrest, is cooling beneficial? And this is referring to some work that was done while I was a fellow in the lab, where we cooled the animals after they were already in cardiac arrest and showed that it improved outcomes. So that's a very different use of hypothermia. And one point to bring up is, we talked about, Lance brought up a lot about oxygen and mitochondria and decreasing the body's need for oxygen and blood flow. But if you think about the difference between like 37 degrees centigrade and 34 degrees centigrade, that's only 3 degrees. Does that really decrease oxygen needs that much? Or is it doing something else? This is a diagram that actually Peter Safar, along with Pat Kochanek, who took over the Safar Center from Peter, put together. I think they did this after a bottle of red wine. Maybe it was Madeira, I'm not sure. It's actually scientifically true, but it looks like it's a big mess. But it actually shows what's going on in neurons during ischemia and reperfusion, suggesting there's a lot more that hypothermia could do because it probably affects a lot of these chemical cascades. And it's not just decreasing oxygen metabolism. Well, work in our lab as well as others show that cooling after arrest was helpful. This led to a couple of clinical trials. This was one done in Europe, and this was done in Australia. Both of these came out in the New England Journal, and this is a big hit because it's like the first time something you could do after somebody had a cardiac arrest actually seemed to improve outcomes. So we started cooling people. There's a lot of excitement about this. This is a picture that I believe is from Germany, and a patient had a cardiac arrest in a supermarket, and the medics had heard cooling is good. So they figured, okay, we're going to be enthusiastic. We're going to start cooling this guy as soon as we can. So they threw a bunch of frozen French fries on top of this patient to start the cooling. There is a patient underneath all that stuff. So there's a lot of enthusiasm for this until people decided to look back at the data a little more and rethink it, because the people who actually didn't get hypothermia actually maybe had fevers, and everybody pretty well accepts that if you have something bad with your brain, whether it's a head injury or stroke or cardiac arrest, having a fever is bad. So a couple studies have been done where they controlled the temperature very carefully in the hypothermia group as well as the so-called control group, and actually you see normothermia and hypothermia here, no real difference. So this kind of put a little bit of a break on this whole hypothermia after cardiac arrest stuff. But there's still guidelines that if you actually have a cardiac arrest and you're not waking up, our Heart Association, as well as the European equivalent, say we should at least control temperature. Don't let you have a fever. Pick some temperature between 32, 36, and stay there for 24 hours, and then prevent a fever for a while after that. So, and this has become termed targeted temperature management, because we're targeting a specific temperature. It may not be that cold, maybe 36 degrees, but it's a target, and we're going to use that for taking care of this patient. How do we do it? There's lots of things we can talk about how you do it. This is just a nice image to show you how we can do surface cooling. We could put special catheters in to help cool people or control their temperature. We can use cold fluids, and there are a bunch of other devices around. The point I always make with medical audiences is, you just do it. You don't get all wrapped up in which device you want to use. Just do it. But you want to control the temperature carefully. I'm going to go through a couple other areas where people have looked at the use of hypothermia that I'll say up front haven't really worked so well, like traumatic brain injury. This is a picture of a CAT scan. The white stuff around the brain on that side, the left side, that's bad. That's blood. So this is a patient who's unresponsive. That's called a subdural hematoma. Should we cool this patient? Well, lots of lab data suggested it could be helpful. And the problem with both cardiac arrest and head injuries and a lot of other things with the brain is you get the primary injury, like that blood, all that white stuff in the brain. There's not much you can do to save that. But the area around it you might be able to save. And that's the so-called secondary brain injury, where there's inflammation, edema, there's swelling. Could hypothermia help with all of that? Unfortunately, maybe not, at least so far. The studies have been disappointing, so the recommendations for head injury basically have been kind of the same as I just said for cardiac arrest. Targeted temperature management. Don't let them have a fever. Control it. Maybe if you've done everything else you can to decrease the swelling of the brain, maybe cooling them could be beneficial, but not up front. Well, how about spinal cord injury? This is a case that was well around the news of a Buffalo Bills football player who had a spinal cord injury on the field, wasn't moving, and they called up the experts on spinal cord injury management and said, what can we do? So he got an early operation, he got steroids, and he got cooled. And as you can see, he's standing here, so it's a win. Whether the hypothermia made a difference, I don't know. But there have been studies with spinal cord injury too, and people have looked at the ASIA scores, the American Spinal Injury Association scores. The one test where getting an A is really bad, because ASIA A means you can't move anything, you can't feel anything. And few people go from A to something better than that. So hypothermia, maybe some small studies maybe improved it, but again, not that clear. And then with spinal cord injury patients, as well as people who've had a stroke or heart attack, there's lots of interest in using cooling, but keep in mind, these patients are often awake. And if you think about right now, if we wanted to cool you down 3 or 4 degrees, your body's not going to like it. You're going to shiver. So that gets really complicated too. And certainly hypothermia by itself has plenty of risks. If you just cool somebody or they get cold because they fall into cold water, it affects basically every organ system. So there's definitely a downside to hypothermia. But let's turn to trauma. This is what I really got excited about. This is a typical kind of patient. Actually, I was a visiting resident at the Shock Trauma Center, which is where I work now. Stab wound to the heart. We do everything right. We do everything we can. That's what the trauma resuscitation unit looked like 30 years ago. And this is some kind of argument about bowling shoes. But even at the great Shock Trauma Center, we couldn't save this person. So here's the problem. Outcome, if you have a cardiac arrest from trauma, what we typically do is we put it in a breathing tube, we give you blood, we open your chest to try and see if there's anything in the chest that we can fix, as well as we clamp the aorta so that whatever, the descending part of the aorta, so whatever blood is left is going to the heart and the brain. Even when we do that, even now, this is data from 20 years ago, it's not any better. Only about 5 or 7% of people live. So we got to do better. So the question is, and oftentimes these patients have injuries that are fixable, we just can't work fast enough to fix them. So is hypothermia potentially the answer? Well, there's a few influences that made us think it could be. So one, I've already talked about hypothermia after cardiac arrest. Cold water drowning, people who drown in cold water often can be underwater for an hour and still be resuscitated. And we've already talked about circulatory arrest for cardiac surgery too. So maybe this could work, but keep in mind, we're doing this after the patient has already had the cardiac arrest. So we've called this EPR, Emergency Preservation and Resuscitation, protection, preservation of the organism during circulatory arrest of 2 hours or longer for transportation, control of bleeding during pulselessness, followed by delayed resuscitation. So we're just buying time to save the person. And so we've done a lot of work in the lab, other people have done some work in the lab, and basically from work in the lab, it seems like, yeah, this could work. So here at the University of Maryland Shock Trauma Center, we are actually trying to do this in humans. We had to pick kind of the best patient population that could benefit from it, and unfortunately in Baltimore and Philadelphia too, there's plenty of people who are injured by either gunshot wounds or stabbings. So we're looking at people 18 to 65 years of age. They have to have had some signs of life within 5 minutes of getting to the hospital. So if you're trying to do any kind of resuscitation research, you don't want to take people that are going to die no matter what you do. You also don't want to take people who are going to live no matter what you do. So we're trying to find the sweet spot in between where we can save people who are otherwise going to die. And we do our normal stuff, it doesn't work, and we say, okay, we're going to switch to EPR. So how does this actually work? This is a nice little diagram showing how it works. The patient has the cardiac arrest. We open the chest. If we get them back, great. If we don't get them back and they meet our entrance criteria, or if they don't meet our criteria, then we would just stop resuscitation. If they do meet our criteria, the next question is, do we have the right team? Because this takes a big team. It's very complicated to do this. Just like the discussion before about cardiac surgery, you need a lot of people to do it. And this is even more than that, because it's cardiac surgeons and trauma surgeons. So if we don't have the team present, we actually will include that patient in our trial as a, quote, control patient that meets the same criteria, but we don't do it because we don't have everybody we need. If we do have the right people, what we do is put a cannula, as was mentioned earlier, a big tube, it's like the size of your thumb, directly into the aorta, because we already opened the chest. And we start this cold saline flush, just pumping in a ton of cold fluid, because the thinking is we want to cool the heart, we want to cool the brain as fast as possible, and the best way to do that is just put cold fluid directly into them. You can't do it fast enough from the outside. Then we let the blood drain out from the right side of the heart and just suction it. At some point, we release the clamp that was on the aorta, so now we're cooling the whole body, not just the heart and brain. We go down to 18, similar to what was discussed earlier about deep hypothermic circulatory arrest. And then we take the patient to the operating room. And in the operating room, we've got two teams. We've got the cardiac team that's going to put the patient on full cardiopulmonary bypass. And we've got the trauma team doing what they need to do to fix the injuries. And this is just set up as a feasibility study where we get 10 people who we do EPR on, 10 who meet the same criteria but we don't do it, and we'll look at the data and move on. As I mentioned, this takes a huge team because you've got the trauma surgeons, the trauma resuscitation unit team, which is basically an emergency department, trauma anesthesia, perfusionists, cardiac surgeons, the operating room staff, cardiac anesthesiologists, blood bank. All those people need to help make this important. If you're ever trying something new in medicine, you got to really practice, so that when you do it, because this is something that's obviously very rare, so we want to have everybody ready to go, whatever this could happen. Now, I'll take one quick aside before I finish about how we do this from an ethical standpoint. Obviously, you can't get consent from these patients, nor can we get consent in a timely fashion from their family. So we have to do what's called community consultation, where we go out in the community and talk about it, and the public disclosure, where it's out in the media so people know that we're doing this in this community. Once you do that, you have no control of what happens to it. Once it's out in the media, it's kind of like when it's out on the internet, it's out there. So the day after I started working at the University of Maryland, the New York Times had this story, this headline about what we were doing. When we did the community consultation in the city of Baltimore, clearly it was a very slow news day. They put us on the front cover and talked about the community outreach, not so much the actual facts of what we were trying to do. And the other thing is you have to give people an opportunity to opt out and wear a bracelet that says, "Don't let Dr. Tisherman take care of me." But the other, as I said, once it's kind of out in the media, you have no control over it.
In which case, all bets are off.
I'm gonna need some suction.
I'm replacing all of the patient's blood
With ice cold saline. Who can tell me why?
The theory of cold infusions that can create a temporary suspension of animation.
Bingo.
That's a man on that table, Leanne.
We're going to kill him to save him.
The cold infusion. It's an experimental procedure.
This was the first patient on the first episode of a TV show that fortunately did not last long. But the patient survived, so I'll say that. And we're not trying to kill them to save them. They're already trying to die on their own. And as Lance brought up earlier, we're not trying to bring back people from the dead. What we're trying to do is prevent people who are actively trying to die from whatever happened to them from actually dying and bring them back to having normal, productive, happy lives. That is our goal. So whether or not, heading into the future, will this really be what people in the sci-fi world would call suspend the animation? Will we potentially have humans that are like flies that were in Madeira and were resurrected? I don't know. It would be kind of cool, though, to kind of go to sleep and wake up 100 years from now and see what's happening. But we'll see. But I think definitely more to come. And I'm really looking forward to hearing more about what DARPA is doing, too, because I think all this can come together, because we focused on hypothermia, but perhaps focusing on some more detailed chemical cascades, adding things to the cooling process could allow us to actually do this right and have a long period of time that will buy us time as surgeons to fix patients who have injuries that are otherwise lethal. So really appreciate the opportunity to talk to you this morning. Thanks for having me.